Hey, good afternoon. My name is Maitland, and greetings from New York. I have the pleasure of talking about the role of inflammation in individuals that have Ehlers-Danlos syndrome or hypermobile spectrum disorder and how it may be contributing to fatigue. These are my conflict of interest, which really do not play into what I'm going to be talking about today. But I want to talk about the fact that fatigue, the Band-Aid for fatigue has really been lifted off the map because of SARS-CoV-2 or COVID infections. But we understand the role of fatigue in other chronic illnesses, including ME/CFS, which can cause millions of individuals to have debilitating fatigue, causing them to miss work and also have compromised activities of daily living. And a lot of it has pointed to the fact that there might be an impairment in getting resources into the body, and then how the body utilizes those resources, which was recently proposed is a supply and demand issue. And one way of thinking about fatigue in individuals is that they have an increased demand because of energy resources going to unnecessary inflammation. And then the inflammation may be impacting the body's ability to efficiently bring in supplies in order to function efficiently. This was recently proposed by some researchers at University of Texas, talking about the role of chronic fatigue causing debilitating diseases, mostly thought of in the setting of either cancer-related fatigue or chronic fatigue. But I think this applies to individuals that have a musculoskeletal hereditary disorder of connective tissue, which makes all their organ systems less efficient in bringing in things that what it needs, and also because of ongoing microtrauma, there's a low-grade inflammatory process that's just robbing the individual of their energy and contributing to this very debilitating disease. So in many ways, if you think about how to tackle fatigue, there are plenty of articles, especially nowadays in the setting of long COVID or post-acute SARS-CoV-2 infection. And they basically say, address your sleep, address your diet, try to exercise, stress management, both physical and emotional stress, and then look for solutions that maybe that will help you tackle the underlying medical conditions that may exist. And one of the things I would think about in individuals that have Ehlers-Danlos syndrome or hypermobile spectrum disorder is that there may be issues with the connective tissue, and embedded in the connective tissue, you have the mast cells, which act as first responders, recognizing dangers. And you hope that those chemicals that the mast cells release are going after physical injuries, infectious agents, or chemicals, whether manufactured or naturally occurring, such as in stinging insects. But sometimes, and we've seen a rise in the release of mast cell activation disease in that there's inappropriate release of chemicals that can impact the function of each organ system where the chemicals are released. And right next to the mast cells are the somatosensory nervous system. And so it's not unusual to see this triad in individuals that have connective tissue disease. They're also having autonomic dysfunction as well as mast cell disease. So in many ways, to tackle fatigue, you have to kind of identify the underlying medical conditions that may be contributing to the increased risk of inflammation, increased risk of compromise of the organ functions, which was originally identified by this article by Dr. Castori in 2012 that showed that joint hypermobility isn't just a musculoskeletal issue, but it's associated with immune dysregulation, cardiovascular dysautonomia, exocrine gland dysfunction, and chronic fatigue, as well as pain syndromes. And so in order to have someone who's having fatigue in the setting of a heritable disorder of connective tissue, you have to identify whether or not you have these conditions. And if so, then what are the best therapeutic regimens to try to tackle the connective tissue issues and the disorders that travel with these heritable disorders of connective tissue. So in 2015, Dr. Hamanet and his colleagues in France did a large cohort showing that of over 600 individuals that had Ehlers-Danlos syndrome reported fatigue and problems with vigilance. Over 90% of the individuals reported sleepiness and feelings of exhaustion, which was not resolved with sleep. So in some individuals, it's very worthwhile to screen for a connective tissue issue and then also to screen for the disorders that travel with Ehlers-Danlos syndrome, including mast cell activation disease. So just to get an idea of some of the things that these individuals were talking about, they're talking about inability to take a good breath in, which is called dyspnea. They're talking about autonomic dysfunction, where their blood pressure was leading to inadequate blood supply to several organ systems, including the brain, the heart, as well as the lungs. They're talking about gastrointestinal stress, including constipation and alternating diarrhea. And because of the fragile tissues, there was increased risk of bleeding, especially for women with their menstrual cycles, which would lead to anemia. And then they were talking about cognitive as well as proprioceptive disturbances. So you can see that several parts of the body, when you have a connective tissue issue, and by the time you're this symptomatic, every different organ system seems to be misbehaving. So when you're thinking about an individual that has Ehlers-Danlos syndrome or hypermobile spectrum disorder, there have been three major conditions that have really been talked about, including the fact that a lot of these individuals have musculoskeletal issues, sometimes often referred to as seronegative rheumatoid disorders. They've also been known to have autonomic dysfunction and, again, mast cell activation disease. And I'd like to lean into a paper that Dr. Brock, Mr. Prendergast, and I had published 2 years ago, looking at the role of mast cell dysfunction in individuals that have Ehlers-Danlos syndrome as hypermobile spectrum disorder. And what was surprising in that individuals that claimed that they had mast cell activation disease, nearly 1 out of 5 had evidence of Ehlers-Danlos syndrome, mast cell activation disease, and also had a deficiency in other compartments of their immune system, which would lead to chronic low-grade inflammation. So mast cell activation syndrome was only coined in 2010 after thousands of individuals were presenting to allergy immunology specialists saying that they were having allergic reactions and anaphylaxis, but their allergy tests were negative. But since then, the latest CDC report showed that 1 out of 3 Americans test positive for allergies. But in addition to allergic or mast cell allergen-driven mast cell activation disease, you have several individuals who are coping with mast cell dysfunction in the upper airway, in the lungs, in the skin, in the gastrointestinal tract, impacting the cardiovascular system, and also the skin. And the latest report shows that 1 out of 50 Americans, whether due to allergies or not, have been treated for an anaphylactic event. So mast cell activation disease and anaphylaxis is on the rise, and individuals that have hypermobile spectrum disorder or Ehlers-Danlos syndrome may be at increased risk for having mast cell dysfunction affect any organ system in the body. So in 2003, the United Kingdom's Work Physicians Group put forth that mast cell disorders now cause problems of increased complexity, commonly involving several organ systems, and patients are often referred to a succession of different specialists, resulting only in confusion. So how are you going to get a diagnosis of mast cell activation disease where you're really talking about at least 2 or more organ systems impacted if you end up going to a pulmonologist because you have breathing difficulties, or you go into a gastroenterologist because you're having quote unquote irritable bowel syndrome, or you go to a rheumatologist who says, well, there are no autoantibodies, so you either have mixed connective tissue disease or seronegative rheumatoid arthritis, you're still not getting a diagnosis. And without these diagnoses, it's hard to get a community of practitioners and also a vocabulary to explain to your family members or your coworkers why you're feeling so unwell. So instead of just talking about quote unquote allergies, it's better to use the term mast cell activation disease. And I'm going to focus on disease because we still lack enough objective lab markers to sustain the diagnosis of mast cell activation syndrome, which is a subset of mast cell dysfunction. So instead of focusing on individual organ systems that have problems, and when you're feeling unwell, you're going to have a tendency to focus on what bothers you the most, it's really important to do a surveillance of what might be causing you to feel unwell. So when it comes to mast cell activation disease, you can have chronic upper airway inflammation in the form of nasal congestion or mucus in the back of the throat. You may be having breathing difficulties in the form of asthma, which to this day, primary care don't screen for. So a lot of these individuals have lower airway involvement and don't know it until they have such a bad attack that they end up in the emergency department or worse. You have food sensitivities, both allergies, such as to soy, wheat, sesame, but also food intolerances, such as to gluten, such that the antibody tests are not helpful in identifying sensitivity to those foods. You have interstitial cystitis, pain syndromes in the joints, and also recurrent pruritic, itchy, red skin syndromes that interfere with your ability to rest. And many of these individuals end up going to the emergency department because of these flare-ups, get steroids, which gives them temporary relief, but then relapse within a few days. So it's really important to kind of take a real good survey of what you might be experiencing if you have chronic fatigue in the form of different questionnaires, and I'll go into more details. But I also want to emphasize in this slide, mast cells kick out a lot of chemicals besides histamine. And depending on what test you look for, you may or may not be able to catch that you're having mast cell dysfunction contributing to your symptoms. So I'd like to just emphasize that I lean into the diagnosis of mast cell activation disease, which basically really focus on, do you have symptoms that are worrisome from mast cells misbehaving? Do you get better with medications that target some of the chemicals or the mast cell dysregulation in the form of degranulation or secretion of inappropriate products? And then hopefully you have a test that points to the fact that your mast cells are misbehaving. And this in turn will then allow you to get a better therapeutic regimen in place to try to help tackle some of the underlying medical conditions that can be contributing to your chronic fatigue syndrome. The reasons why there's such a delay in the diagnosis of mast cell activation disease is because sometimes the patients don't know that they should bring up the fact that they have congestion and sinus issues with their primary care. Most primary care have received little training on mast cell activation disease, maybe 1 or 2 lectures when they were back in medical school. And then, unfortunately, when it comes to newly minted medical conditions, it takes anywhere from 10 to 17 years before the general medical community has an idea about that new syndrome, including primary care specialists. And in this case, many specialists, including allergy immunology specialists, have a tendency to focus on the normal tryptase. But I'll have to tell you right now, there's no normal tryptase. 2% of the population don't have tryptase. Some hypersensitivity mast cell reactions don't involve tryptase. So in many ways, when it comes to identifying mast cell activation syndrome, it's kind of like looking for a heart attack. You have to use several different types of tests in sequence in order to identify whether or not mast cell dysfunction is contributing to your chronic fatigue. So in 2010, the World Health Organization, who focused on mast cell disease, who started to recognize that individuals were having hypersensitivity reactions that were not attributed to either having documented allergies to foods, airborne, environmental substances, or some medications, or a much more rare disease such as systemic mastocytosis. So rather than focus on why the mast cells are misbehaving, let's see whether or not the mast cells are misbehaving and contributing to your symptoms in the first place. And it's a very simple checklist. Do you have signs or symptoms of mast cells misbehaving, such as nasal congestion, neurocognitive impairment, brain fog, headache syndromes, gastrointestinal distress in the form of bloating, nausea, vomiting, or alternating diarrhea and constipation? Are you having breathing difficulties, feeling like that there's a fullness in one's throat? Or are you having episodes of coughing or wheezing or can't take a deep breath in? All of these are signs of potential involvement of mast cell dysfunction. And then do you feel any type of relief when you take medications that target mast cells? This include over-the-counter or prescription histamine blockers, tricyclic agents such as amitriptyline or doxepin, leukotriene modifiers such as montelukast or zolpidem, or mast cell stabilizers such as cromolyn or ketotifen. And then after you get a good story, your symptoms, whether or not you get better with some interventions, do you have test results that support that the mast cells are contributing to your symptoms? This is the 3 criteria, the fourth. Again, do you have mast cell dysfunction possibly acting up in at least 2 or more organ systems, such as I just described? Do you get better with these type of medications that we know that target mast cells or mediators that are released by the mast cells? And do you have any objective validated mast cell activation markers such as tryptase, 24-hour urine collections from methylhistamine, prostaglandin D2, 11-beta prostaglandin F2 alpha, or remembering that mast cells are tissue-based cells, do you see abnormal tissue activation in organ systems such as the gastrointestinal tract or the skin? And if so, it's important to tell the gastroenterologist or the dermatologist to stain for mast cells. Otherwise, if you don't use that CD117 stain that looks after the c-KIT or the peripheral blood stain looking for the c-KIT mutation or activation markers, then you might miss the fact that mast cells are contributing to your symptoms. So focusing on the symptoms, again, these are classic symptoms that are associated with mast cell dysfunction, including hives, swelling, itch, warmth, or redness of the skin, lower respiratory involvement in the form of shortness of breath, coughing, chest tightness, difficulty swallowing, hoarseness, or nasal congestion, gastrointestinal distress in the form of bloating, nausea, stomach pain, cramps, vomiting, or diarrhea, cardiovascular symptoms such as susceptibility to dizziness, lightheadedness, almost POTS-like symptoms. Your skin has a very pale blue hue. Your pulse is bounding or sometimes weak. And then for some of these individuals, they actually have loss of consciousness or faint. As far as neurological symptoms, there's, I would not call it anxiety as opposed to anxiety in the setting of a general medical condition, feeling of impending sense of doom or susceptibility to headaches or brain fog. And then there's actually genital urinary involvement in the form of uterine cramping. For some individuals in the United Kingdom, the way they diagnose interstitial cystitis is based on a biopsy that identifies mast cell dysregulation in the bladder wall. So you can see mast cells, which are in every single organ system, if they're inappropriately releasing chemicals, can cause problems in any organ system. This is the questionnaire that I use to sort out whether or not mast cells may be contributing to a person's symptoms. And I'm happy to provide this for you to use with your own assessment to see whether or not mast cell dysfunction is contributing to your chronic fatigue and malaise and post-exertional malaise symptoms. Whoops. So moving on to the next level of the checklist, I have mentioned these medications before. If you have these signs or symptoms of mast cell dysregulation, do you get better with these type of medications such as receptor blockade of the first histamine receptor, the second histamine receptor, tricyclic agents such as nortriptyl and erdoxatin, glucotriene antagonists, aspirin, ketotifen. And I would put an asterisk on aspirin because for some of these individuals, aspirin can actually make your symptoms worse, as well as other non-steroidal anti-inflammatory agents such as ibuprofen or naproxen. So that's a qualifier that you should use with an allergy immunology specialist to make sure that it's safe. For some individuals that have mast cell activation disease and they have a clonal mast cell disease such as systemic mastocytosis or hereditary alpha-tryptosemia, there are other agents that may be available to help reduce the burden of mast cell dysfunction contributing to your chronic symptoms. And as far as the data, really, it's important to kind of focus in on the activation markers that are known to lead to therapies that target this type of activation events from mast cells. So there have been 4 different forms of mast cell activation events for which some medications that are typically used for classic allergic or immediate hypersensitivity reactions will work better than other medications that target other chemicals that are released from mast cells. So we have a tendency to lean into the serum tryptase, the 24-hour urine collections for prostaglandins, as well as histamine. But again, it's really important to focus in on that the mast cells are tissue-based cells. So a biopsy of the esophagus, the stomach, the colon, the small intestines to see whether or not the mast cells are misbehaving, as well as the skin. There are other other chemicals that are released by mast cells, including chymase, carboxypeptidase, serotonin, platelet activating factor, neuropeptides. Yes, mast cells do release them, but when it comes to medications that are recommended for certain forms of mast cell activation events, if you have these elevated chemicals, it doesn't necessarily point to just mast cells misbehaving. There are other cell populations that can also release these enzymes or substances. Once you secure the diagnosis of mast cell activation syndrome, which is a subset of mast cell activation disease, it's important to figure out why are the mast cells misbehaving. 20 years ago, we focused on why the mast cells are misbehaving. Now we focus on the mast cells are misbehaving. There's different ways that mast cells can misbehave, and there's different ways that mast cells can misbehave in a single individual. So I have patients that have systemic mastocytosis and then also have non-clonal or secondary mast cell activation events because they have positive allergy tests or they have an autoimmune disease such as Hashimoto's or Graves' disease or rheumatoid arthritis or myasthenia gravis, because the mast cells have receptors to autoantibodies. And if the body is stressed, then the mast cells might act on those markers and cause disease or cause exacerbation with pre-existing conditions. You also have individuals that have physical urticarias, meaning there's physical activities such as going from a cold room to a hot room, or you're striking your skin, or you're wearing close, tight-fitting clothing, and then you break out with hives, these red itchy welts or swelling. And then, like any other part of the body, the mast cells can become a target of an autoimmune process called chronic autoimmune urticaria. And it's not just urticaria. That antibody can latch onto any mast cell in any part of the body. So it can contribute to lung distress. It can contribute to gastrointestinal distress. And then I'd like to point out one marker for mast cell activation syndrome called hyperalpha-tryptosemia, which was only described in 2016. And what's really interesting in these individuals, which affect about 7% of the Caucasian population, that these individuals have evidence of skin and tissue fragility consistent with hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome. They also have autonomic dysfunction in the form of POTS, and they have mast cell activation disease. So here you have a mutation that's in mast cells that is causing a connective tissue issue, that's causing autonomic dysregulation and contributing to increased susceptibility to hypersensitivity events such as mast cell activation disease. The reason why you want to figure out why the mast cells are misbehaving, it will then guide you to what therapies you can consider to try to dampen down the inappropriate mast cell activation events. So if you have positive allergy tests like IgE to foods or to environmentals, you have avoidance measures, such as if you have dust mite allergy, you can use dust mite covers. If you have milk allergy, you're told to avoid milk or potentially lead to desensitization protocols, such as allergy shots or allergy drops for environmental allergens, or oral desensitization to foods in a safe fashion. You have medications that are known to contribute to allergen-driven mast cell disease, such as histamine blockade, leukotriene blockade, the tricyclics, which I mentioned before, mast cell stabilizers such as ketotifen or cromolyn. And then there's one biologic that is available that's known to go right after the mast cells themselves that contribute to these type of hypersensitivity events, and that's omalizumab. It's also important to identify that a lot of individuals have other components that are lacking in their immune system that may be contributing to a acquired or primary immunodeficiency syndrome. We found that at least 1 out of 5 individuals that came from my practice for evaluation for mast cell activation disease were lacking antibodies or lacking protective antibodies against common pathogens such as bacteria as Streptococcus pneumoniae or Haemophilus influenza, or don't have adequate protection against viruses such as measles, mumps, or varicella. And then also some of these individuals who were having mast cell activation disease actually had evidence of infection that was contributing to their symptoms, such as coronavirus, which is SARS-CoV-2 infections, or long COVID. We have individuals that had hepatitis identified because their mast cells were misbehaving, causing hives or respiratory distress, bacterial infections, especially individuals that had antibodies against other forms of strep that would not clear that bacteria. And then you also have parasitic tick-borne infections such as Lyme, Borrelia, and now in the States, alpha-gal, which is meat allergy. And then lastly, because mast cells do have the ability to recognize other forms of immunoglobulins or antibodies, individuals that have autoimmune disease, it's very possible that mast cells also contribute to those symptoms. So I also wanted to point out that it's important to realize that sometimes some disorders look like mast cell activation disease, but it's actually due to another comorbid disorder. Because mast cells have a very close relationship to nerves in the tissue, it's important to see whether or not you might have an autonomic dysfunction. And this is work by Taylor Dowdy and Andrew Wright that originally proposed that POTS travels with mast cell activation syndrome. And then these are other conditions that also can mimic mast cell activation syndrome, mast cell activation disease, especially autonomic dysfunction such as POTS. And this is just wanted to show you the overlay between individuals that have mast cell activation disease on the left and individuals that have POTS on the right. And that's because, again, mast cells talk to nerves in the tissue all the time. And just some more data suggesting that mast cells and nerves share chemical mediators, and it's not uncommon for medications that target the mast cells can also target the somatosensory neurons as well. So if you have chronic fatigue, like you feel like you're being buried alive, your body is that sluggish, it's really, really important to establish whether or not you have mast cell activation disease. And again, just a reminder of the criteria. Do you have signs or symptoms that mast cells are misbehaving? Do you get better with medications that target mast cells? And what tests do you have to support that your mast cells are the culprit in contributing to your chronic fatigue, because you're having ongoing congestion issues, you're having ongoing skin disruption, you're having ongoing gastrointestinal distress or pain syndromes. And then once you're able to identify whether or not mast cells are contributing to your symptoms, this is a chronic disorder, a low-grade inflammatory process that's sapping your energy. And if you focus on identifying whether mast cells are misbehaving, using appropriate therapeutics that have been shown to be effective in reducing mast cells, and then monitoring for potential side effects, you can tackle one major component to which contributes to chronic fatigue syndrome. I want to thank you for the opportunity to talk about immune dysregulation that may be contributing to chronic fatigue. I have a lot of people to thank, but I have to tell you, my interactions with the EDS Society really has broadened my horizons, and truly appreciate all the opportunities that I've had to kind of talk about now my favorite subject, mast cell activation disease.